dear doctors, so in the next few minutes, I would like to define the diabetes, some of the important milestones in the history of the diabetes and its management. So let us see this case. 52-year-old male comes to you with blood glucose of 198 and 362, both fasting and the postprandial. He is not known to have the diabetes, no past history of the diabetes. He was discovered to have these values during a routine health checkup. So 52-year-old, no history of the diabetes, routine checkups, fasting 198, postprandial 362. So what proportion of patients with diabetes are unaware that they have the condition? More than 50% are asymptomatic. See, in fact, the most common symptom of the type 2 diabetes is no symptom at all. Even 80 to 85% of our population, as they are asymptomatic, they don't go to a doctor. So in Andhra Pradesh, the people visits the doctor only when they have the symptoms. Say some sore throat, some abdominal pain, or some fever, some loose motions, or some backache, etc. So as long as they are asymptomatic, they don't visit the doctor. So this is the ideal time for all of us. With any complaint, the patient comes to your doctor. Whenever you write an investigation, please add blood sugar also. Even though the patient is in the icterus, okay, jaundice, add blood sugar. The patient is in GE, you are writing some, say, typhoid or some other investigations, add blood sugar. So it's very, very important investigation. That is how you pick up the asymptomatic diabetes in your fold. What symptoms can alert one to the presence of the diabetes? So the answer is clear. What symptoms? Mostly no symptoms. But if at all the patient have the symptoms, what are the common symptoms of the type 2 diabetes in our area? Maybe asthenia, maybe polyuria, some tingling and numbness sensation of the feet, okay, sleep disturbances, sometimes polyphagia, sometimes the polydipsia, okay, sometimes vulvoposthitis, vulvovaginitis, some fevers, some carbuncles, okay, some gastropathies, maybe some gastroenteritis. So these are the common symptoms. The people of the diabetes, unknown diabetes, they visit a doctor. So most of these symptoms are due to the complications of the diabetes. So the earlier speaker, Dr. Fani, saying that one of the two causes of the blindness in India is uncontrolled diabetes, diabetic retinopathy. One is a mature cataract, neglected cataract. It's a preventable blindness. So neglected cataract, and number two is diabetic retinopathy. So in India, diabetes being diagnosed by all the specialties, not only by the endocrinologist or the physicians, because whenever the patient comes to that particular complaint to that particular specialty, he diagnoses. Sometimes dermatologist diagnose the diabetes, sometimes the gastroenterologist diagnose the diabetes, sometimes the ophthalmologist diagnose the diabetes, sometimes the urologist diagnose the diabetes. So this is a very, very important symptom. So what symptoms? Any symptoms depending on the complications of the diabetes or involvement of the system of the diabetes. What complications of the diabetes can a patient have at the time of the first diagnosis? Again, the percentage of the people with the complications visiting first time to the doctor. Is it 10%, 20%, 40%, 50%? So nearly 40 to 60% of the people in India, they present with the complications even at the time of the diagnosis itself. That means they have been living with the diabetes without knowing that they are having the diabetes, and they visit the doctor when they have the complications. In the same way, every day I get at least 1 or 2 referrals from the ophthalmology friends saying that defect of the vision, visited the ophthalmologist, diagnosed retinopathy, and control the blood sugars very effectively. The fasting blood sugar 200, postprandial blood sugar 350, and non-proliferative diabetic retinopathy or proliferative diabetic retinopathy, and then refer to a physician or endocrinologist or a diabetologist for the proper control of the diabetes. So this is the very, very important. So the 3 things here is the diabetes is very common in the society, asymptomatic nature, and most of the diabetics are left undiagnosed and not diagnosed at the earlier time. So definitely they present with the complications even at the time of the presentation itself. So that is the inference of this slide. Very, very common in our society, such people. Another case, a 85-year-old male, diabetes of 42 years duration. Okay. You are pleased to find that he has absolutely no evidence of any chronic diabetes complications. See here, earlier case, 52 years, diabetic. 198, etc. and etc. Asymptomatic. Here, 85 years. Age is 85 years and already 40 plus diabetic life. And he has not having any complications. Can an individual with diabetes enjoy a normal lifespan? Yes or no? Yes. Provided if you keep the fasting blood sugar around 100, postprandial blood sugar around 150, and HbA1c around 6.5, and eye over the complications, early onset of the complications like your urinary microalbuminuria for the early detection of the nephropathy, or your ECG or an X-ray, etc., or TMT or calcium score, etc., to define early coronary artery disease. Okay, any your 10 grams monofilament examination or vibration sensors or etc. to rule out any early diabetic foot neuropathies. So definitely these people can enjoy the normal lifespan even after the 40 years of the diabetic life, even at the age of the 85 years. Okay, can diabetes complications be prevented totally? Not totally, but definitely 85 to 90% we can prevent the diabetic complications, because the diabetes complications are directly proportional to two things. One is duration of the diabetes. Number two is control of the diabetes. Okay, so as the duration is going on, so definitely these people will have some amount of the complications. But if you control the blood sugars very effectively, if you keep the HbA1c around 6.5, even though they have the complications, that can be manageable with your medical management. What I mean to say, even though the patient is having the diabetic neuropathy at the age of 80 or 85 years, he will not go for the amputation. Even though the fellow is having a retinopathy at this age, it should be the non-proliferative diabetic retinopathy and doesn't require any laser therapy. Okay, so that is very, very important. So these two cases will tell you, if you control the blood sugars very effectively and if you keep the blood sugars under control, so definitely they can enjoy the normal lifespan. Here another case, a 65-year-old lady evaluated for the diabetes and its complications, diabetes of 16 years duration. Okay, so she is found to have the fasting and the postprandial 108 and 146, HbA1c 6.8. However, further evaluation reveals the presence of proteinuria and moderate non-proliferative diabetic retinopathy. See, her age is 65 years. Diabetic life is about 16 years. Now the fasting is under good control, 108. Postprandial is good control, 146. HbA1c is excellent. Somewhere between 6.5 and 7 is the good. So 6.8 is not bad. But she is having nephropathy and also neuropathy, retinopathy. See, this patient is having both the proteinuria, that means nephropathy, and also the retinopathy. See, nephropathy and retinopathy are very close friends. So the retinopathy, all the retinopathy people should be screened for the nephropathy, vice versa. Why should this patient with apparent good control of the diabetes develop the complications? See, the fasting is good, PP is good, HbA1c is good here, 100 plus or 140 plus or 6.5 plus, good. But she developed the complications. Proteinuria and also the retinopathy. So what determines whether a patient develops the diabetes complications or not? So what is our answer for the first question? Why she developed the complications? So this fasting and the postprandial is of today's values. Your HbA1c is the last 3 months average. So what was her control in the initial period of the diabetic life? Now she is 16 years duration. So whatever her diabetic control in the first 5 years or first 10 years or first 15 years, that matters a lot. So that is called metabolic memory. Okay, so if you control the blood sugars very effectively from the day one, these people will not have any complications, even though the control is not good after some time. So the initial days of the diabetic life is very, very important, very crucial to avoid the long-term complications of the diabetes. So you all agree with me that from tomorrow onwards, you identify the early diabetics, you control the early diabetes very effectively, and you are giving the person as well as the society a great boon, because you are avoiding the long-term complications. You are avoiding the kidney transplantation, you are avoiding the laser therapy, you are avoiding the bypass, etc. and etc. So this is the metabolic memory. So she must be having the diabetes for the last 16 years, but the control at the earlier days is not good. Even though the control is good in the recent past, but because of the poor control in the earlier days, she developed nephropathy and retinopathy. So what determines whether a patient develops the diabetes complications or not? is the early first phase of the diabetic life control. So this patient concedes that her diabetes control has been poor for the past 5 to 6 years. Only recently improved following the initiation of the insulin therapy. Okay. She also has uncontrolled hypertension. So that is a very, very important, deadly duo. So all the complications of the diabetes will be multiplied in the presence of hypertension. So please see that ABC is very important in diabetes. What do you mean by A? A is A1C, that is your diabetes control. B means blood pressure. C means cholesterol. So in all the diabetic individuals, A, B, C is very important. Keep the A1C around 6.5, fasting and postponed, etc. So control the diabetes. So don't be happy with the control of the diabetes alone. What about BC? B means blood pressure. So keep the blood pressure systolic around 130 and the diastolic around 80 or 85. So that is your target. Less than 180, 130 by 85 or less than 120 by 80. That is your BP target depending on the age of the individual. And C is the cholesterol. That is dyslipidemia. So LDL, earlier it was 130 and then the 100, then 70, now around 50. It is very easy to say that you should keep the LDL at 50 or the 70, but it is very difficult. Even with the 40 milligrams of your rosuvastatin or 80 milligrams of the atorvastatin, unless you introduce the non-pharmacological measures. That is your dietary approach, your exercise, your physical activity, your yoga, your meditation. So these are all plays a major role in the control of the blood pressure, cholesterol and diabetes. So the role of the diabetes, to keep the diabetes into euglycemia, you need non-pharmacological measures also. So along with the drugs, along with your OHS or the insulin, so don't underestimate the value of your dietary approach, your physical activity, your yoga and meditation and etc. Of course, cessation of the smoking is very, very important. Moderation of the alcohol is very important. 6 to 7 hours sleep is very important. So these are the important measures to keep the diabetes under control, not to have the complications in the near future. So good. So I have shown you the 3 cases. So all the 3 cases are very common in our practice. Okay. So now what is the BP? Hypertension. So define the hypertension. The systolic should be more than 140 and the diastolic more than 90. Okay. So in all the diabetic individuals, you keep the blood pressure as close to the normal as possible. So the normal blood pressure is systolic 120, diastolic 80. So systolic 121 to 139 is pre-hypertensive. Diastolic 81 to 89 is pre-hypertensive. So once it touches 140 systolic or 90 diastolic, it is hypertensive. It is 120 by 80, less than 120 by 80 is the normal. And if you keep the blood pressure between 121 to 139 or 81 to 89, they are the pre-hypertensive. So to avoid all the complications of the diabetes, so keep the blood pressure as the normal. Normal means less than 120 by 80. But it's very easy to say that 120 by 80 our target. Sometimes it's very difficult, provided if the person's creatinine is elevated. So that means CKD. The CKD population, the blood pressure is very high, accelerated hypertension or stage 3 hypertension, 200 by 120, 240 by 160 is a very, very common, where your hands are tight in using the ARBs because already the creatinine is 4.5 or the 5. So you have to use the calcium channel blockers, you have to use the beta blockers, you have to use the alpha blockers, you have to use the central acting drugs like the arcamine, and you have to use the loop diuretics, because once the creatinine is 4.5 or the 5, if you see the GFR, it will be 20 or 15 or less than 15. So where you should not use the chlorthalidone or chlorthiazide. So where you have to use the loop diuretics once the GFR is less than 30. So 2 loop diuretics in our hand are the furosemide and the torsemide. So that furosemide, the torsemide also you have to use in the larger dosages, not as the 20 milligrams of the Lasix or 40 mg of the Lasix, maybe 80 mg or 120 mg. So in the foreign countries, no, even the 400 mg of the Lasix is available, furosemide. So for us 400 mg. So that means 10 tablets of your Lasix in India. So that is the number of the antihypertensive medications. We use it in the presence of the CKD or the DKD. DKD means diabetic kidney disease. CKD means chronic kidney disease. Again in India, for the CKD, 2 reasons are very common. 2 diseases are very common for CKD in Indian population. One is diabetes. The second one is hypertension. Unfortunately, both are very commonly associated because of the common environmental factors. So that is how we have to treat the hypertension. So it is very easy to say the numbers, but it's very, very difficult to achieve the these numbers. So that is why you have to uptitrate the dosages. So don't be happy with the 40 milligrams of the telmisartan or 5 milligrams of the amlodipine. So you have to see the blood pressure and keep the blood pressure under control. For that, you have to increase the doses of these drugs. So always see that the blood pressure should be under control. Otherwise, all the diabetes complications will be increased or multiplied. So now what is diabetes? With this background, see, the diabetes is a metabolic and vascular syndrome. So we know that metabolic disease, diabetes, it is a carbohydrate metabolism, protein metabolism, and also fat metabolism. Not only the carbohydrate metabolism. Diabetes means not only your carbohydrates, but also the proteins and the fats. So to reduce the blood sugars, not only in reducing the carbohydrate, you have to improve the protein and you have to reduce the fats. So that is what your Veeramathineni diet. So in most of the Veeramathineni diets, he gives a lot of the protein, no sugar, no carbohydrates, and lot of the fat. So again, the fat will be converted to something else. So that is the metabolic disease. So don't say that diabetes is a carbohydrate metabolism. Diabetes is a carbohydrate, protein, and fat metabolic disorder, and it is a vascular syndrome. So nowadays, diabetes means almost equivalent to your cardiac problems. So that is the reason type 2 diabetes is called as a myocardial infarction equivalent. And if you see the two people, one fellow discharged from a physician with a diagnosis of type 2 diabetes, another fellow discharged from the Apollo with a diagnosis of acute myocardial infarction. If you follow these two cases for 10 years, the mortality is the same in both the diabetes as well as the post-MI population. So that means that diagnosis of the diabetes itself is a myocardial infarction equivalent as long as the long-term complications is the concern. So don't think that diabetes is a very simple disease. It is a very simple provided if you keep the HbA1c around 6.5. On the other hand, it is very, very difficult and very tough disease if you keep the HbA1c beyond 10 or the 11 or the 12. Even today we see some cases with HbA1c 15, 16, 17 also. So it is a multiple etiology, not a single factor causing the diabetes. So it's a multiple factor. Maybe the physical inactivity, maybe your obesity, maybe your high carbohydrate consumption, maybe high calorie diet, maybe sleep disturbances, maybe strong family history, maybe your genes. So these are all very, very important etiological factors to cause the type 2 diabetes, characterized by the chronic hyperglycemia. It's not acute hyperglycemia. Unlike in a COVID period, when you are using a lot of the steroids, some of the people, they develop the hyperglycemia. So there is only short-lived hyperglycemia because of your steroid induced. But this diabetes, to consider that, to call him a diabetic, it should be a chronic hyperglycemia, not an acute hyperglycemia. With the disturbances of the carbohydrate, fat, and protein metabolism resulting from the defects in the insulin secretion. So that means you have to blame the pancreas. Alpha cells, beta cells. Beta cells secrete the insulin, alpha cells secretes the glucagon, both are antagonistic. So in diabetes, so there will be the beta cell defect as well as the alpha cell hyperactivity. So hyperglucagonemia and hyperinsulinemia. So this is the insulin secretion defect in the pancreas, and insulin action are the both. Insulin action acts at the level of the liver, acts at the level of the muscle, acts at the level of the fat. So this is called insulin resistance. So insulin resistance are three levels: at the level of the liver, at the level of the muscle, and at the level of the fat. So insulin, what insulin do? Insulin promotes the entry of the glucose into the muscle. Insulin promotes the entry of the glucose into the liver. Insulin promotes the entry of the glucose into the fat. So this is the insulin resistance. Or both. Most of the times it is both. It is very difficult to say that this fellow is having more insulin resistance, this fellow is having more insulin deficiency. But the people with abdominal adiposity, the people with Indian background, we are having the more insulin resistance when compared to the insulin deficiency. Both leading to the changes in the both small blood vessels, that is microangiopathy. So that is your neuropathy, nephropathy, and retinopathy, and large blood vessels or macroangiopathy. So that is your coronary artery disease, cerebrovascular diseases, and peripheral vascular diseases. So this is the definition of the diabetes. It is a metabolic and vascular disease, multiple etiology, chronic hyperglycemia, disturbance of all the three metabolisms, resulting from either insulin deficiency or insulin resistance or the both, and then if left untreated, will lead to the both microvascular and macrovascular complications. And we also add in India, not only the micro and macrovascular complications, infections also plays a major role for the early death in our diabetic individuals. You all agree with me that whenever you see a medical intensive units, most of the cases are the sepsis. And important reason for the sepsis is uncontrolled diabetes. And if you see in ICU, sometimes one injection common to all the people in the ICU is the insulin. So that means most of the people are diabetics there. The same thing happens even in the neuro ICU also. So that means that diabetes is a very, very important cause for the hospitalizations. Diabetes is an important cause for your intensive care unit admissions. So unless you control the diabetes very effectively, so these people, they die very high. So the mortality is very, very high in the presence of the uncontrolled diabetes. So what are the milestones in the diabetes? The first report on the diabetes 3,500 years ago. So this is the Egyptian oldest preserved medical document. This is the one. So Aratus is the first fellow, first to use the term diabetes, 2nd century. So this is our people. Charaka and Susruta in the 2nd and the 5th century. See how beautifully they analyzed the diabetes without any blood sugar estimation or urine sugar estimation, or without your fundus examination or your ECG or X-ray, even no stethoscope. So they say that they differentiated diabetes mellitus from the diabetes insipidus. Okay, they recognize two types of the diabetes. One is Krisha, second one is Sthola. Krisha is lean diabetes. So the lean is mostly type 1 diabetes. Sthola means obese diabetes. That means they are type 2 diabetes. Type 2 diabetes. They noted that diabetes runs in the families, especially Sthola diabetes. So the type 2 diabetes runs in the families. So these are all observations given by the Charaka and Susruta. Described polyuria and the glycosuria also, honey like urine. They tasted the urine, very sweet. So this is the diabetes mellitus. They tasted the urine of the diabetes insipidus also, that is tasteless. So that is diabetes insipidus. Even though those two people are having the polyuria, this is diabetes mellitus, that is insipidus. They described the basics of the treatment for the diabetes. What the treatment they have given for the Sthola diabetics? Physical activity and the diet. Control the diet. Do the more and more physical activity. Your insulin resistance will gone and you live for the longer period. That was the treatment given by them. And noted that lean diabetes is difficult to manage. They know that lean diabetics, that means type 1 diabetes. Type 1 diabetes, what is the treatment of the choice? 1, 2, 3. 1 is insulin, 2 is insulin, 3 is insulin. How long? 1 year, 2 year, 3 year, lifelong. Lifelong. So they die. So the Charaka and Susruta, at that time there was no insulin. So they say that lean diabetes is difficult to manage. So they are going to die prematurely. See the beautiful observations given by them. Even today, they hold good. They are all true even today. We have the two types, type 1 and the type 2. And type 2 is very easy to manage with your diet approach and etc. and etc. You don't require any drugs if you diagnose the type 2 diabetes in the early stages. So I only advise the physical activity. I only advise the dietary approach. So let us see, when the fasting blood sugar is 121, postprandial blood sugar is 220, A1C 6.7, you are diagnosed type 2 diabetes. So what is the treatment? No metformin, no sulfonylurea, no SGLT inhibitor, no insulin, only physical activity. Dietary approach. And review after 3 months. After 3 months with a good physical activity and good dietary approach, the fasting 90, postprandial 140, HbA1c 5.7 of the 6. So that's what Charaka and Susruta told at that time itself. So this is the very, very important documents report on the diabetes in Indian population. So then comes to the pancreas takes the center stage. See, earlier times, they thought that earlier the diabetes is because of the renal problem, renal disease. Why they say renal disease? Because these people are pouring lot of urine. So it is a polyuria. So the defect is in the kidney. So the cause for the diabetes mellitus is the kidney. So some people say that no, it is not the kidney, it is the GIT. Why they are saying that GIT? Because of the more protein diet, because of the less carbohydrate diet, their urine output is reducing. So something concerned with the gut, not with the kidneys. And some people they say that no, not the brain, not the kidneys or the gut. It is the disease of the brain. So some people who are eating more, the binge eaters, so they are getting the more diabetes. So something concerned with the brain. So as long as these people identify the islets in the Langerhans. So then they say that no, it is neither the brain, nor the kidney, nor the gut. It is the disease of the pancreas, which is secreting the beta cells, secreting the insulin. So the defect of the insulin deficiency is causing the diabetes. See the Paul Langerhans, 1869, from Germany. See, at that time only a medical student, two medical students, they are given a lot of input in the diabetes. One fellow is a Langerhans, another fellow is not Banting. Best. Best is a medical student. Banting is an orthopedic surgeon. Okay. So the best is a medical student. Again, the Paul Langerhans is also a medical student. He discovers that the pancreas contains the two systems of the cells. You know what are the two systems? One is exocrine function. The second one is endocrine function. One set secretes the normal pancreatic juice. The function of the other was unknown. So he could not identify what is the exact cause for this second secretion, Langerhans. But he identified there were the two functions of the pancreas. One is the exocrinic function. The second one, chori, because he was not known whether this secretion is an endocrine or not. Several years later, these cells are identified as the islets of Langerhans in his honor. Okay. Now 1889, German physician Minkowski and the Joseph van Mering removed the pancreas from a healthy dog to find swarm of the flies on the dog's urine. On testing the urine, they found there was sugar in the dog's urine. So they did the pancreatectomy dogs, and then the urine contains a lot of the sugar. So that's how they know that. So this is all diabetes is nothing but it's a pancreatic disorder. Okay. So in 1901, Eugene Oppe mentions diabetes mellitus is caused by the destruction of the islets of the Langerhans. See here, Oppe, destruction of the islets of the Langerhans and occurs only when these bodies are in part or wholly destroyed. So he is much more, Oppe is saying that it is the destruction of the beta cells. So now the story. So Banting was an orthopedic surgeon, but he was posted in the department of the physiology as a tutor. He is an orthopedic surgeon waiting for his promotion. So before the promotion, he was posted in the physiology department as a tutor. But he is very much interested in the doing some work on the pancreas. Okay. So he asked his professor. The professor is the MacLeod, the second one here. He was the professor of the physiology. So the Banting met the MacLeod and requested the MacLeod to give him some lab to do some activities on the pancreas. Then MacLeod, in the first instance, he laughed and he said to the Banting, you are an orthopedic surgeon. Don't make jokes with me. Do your work here. You are just a tutor here. You sit, you come, you sit, you take 1 or 2 classes to the undergraduates and then leave. So that lab work, other things, all our physiology faculty will do that work. Then he upset Banting, and after 10 days or 15 days again he requested the MacLeod several times. So MacLeod said no. Finally Banting went to the principal and requested the principal to say good words to the MacLeod to give him some lab to do something on the pancreas. So finally, on the request of the principal or the dean or DME, whatever you say, so finally MacLeod agreed to give one lab to the Banting. What is that lab? Unused lab. He has 2 labs, MacLeod's. One is used lab, second one is unused lab. So Banting got the unused lab, and then he made all the arrangements in that lab, and he wanted one fellow to be assisted for his activities, for his research. So now present staff, all the assistant professors, associate professors, no one is interested to work with the Banting because he is not having good relations with the MacLeods. So finally he requested at least one medical student you give me. No medical student is interested to work with the Banting because he is not having good relations with the MacLeods. If any medical student works with the Banting, he is going to fail in the examinations. So again, he approached the dean or the principal, and by coin test, he got the best to assist him. No student is interested. Finally, Padma Gan Ramanaru. Madam Padma, you say some number. She said number 60. Okay, that 60 happens to be best number. Best number. So now best is forced to assist Banting for his research on the pancreas. The result, finally, you know that they discovered one of the beautiful molecules in the world. See, the diabetes ligate the pancreatic ducts of the dogs, keep the dogs alive till the SNA degenerate, leaving the islets. Try to isolate the internal secretion of these to relieve the glycosuria. He presented his idea to the James MacLeod, professor of the physiology at the University of Toronto. See, MacLeod was not impressed with the Banting's idea, but agreed to offer him the use of a disused old lamp and the services of an assistant. By a coin toss, medical student Charles H. Best got the chance to assist the Banting. In their experiments, they induced the diabetes in the dogs by removing the pancreas and tried to see whether the glycosuria could be suppressed by administering the fluid isolated from the islets of the Langerhans of the other healthy dogs. And this dog being living for some other days or the months because of the injection of your insulin. So he is the best. First positive results. Marjorie was kept alive with the pancreatic extract injections for 70 days. The dog. Okay. So the dog name was also entered into the history. See, he is the Colip, a great fellow. So Colip being impressed with the Banting and Best experiments, and they prepared the more technically not a purified insulin they prepared. So the Colip is the physics head, and he made the improper or impure insulin extract to the more purified form, so that the allergic reactions are very, very less. So in that way, the Colip helped these Banting and the Best to make this impurified insulin into a purified insulin. So the Nobel Prize for the medicine in the 2023. Say they discovered in the 21, they got the Nobel Prize in the next year, 23. You see, again here is a good thing is the Nobel Prize was given only to the faculty people. Okay, who are the faculty here? Physiology professor and the Banting. So the Banting got the Nobel Prize because he is the orthopedic surgeon, and without doing anything, giving just unusual lab, the MacLeods also got the Nobel Prize because being the HOD of the physiology department. Okay. Then the Banting shared his prize money to the medical student Best. See how gracious they are. Banting shared his prize to the Best. In the same way, then the MacLeod realized it. See, it is almost at the before our cinema end of the story. So all the villains become almost they are very good people at the end of the story. So the same thing, the MacLeods also became good, and he also shared his award with the Colip because he made all impurified insulin into the most purified insulin. So this is the story of the Banting and the Best and the insulin discovery. Now, insulin is the only protein which got 7 Nobel Prizes so far. No other molecule got that much number of the Nobel Prizes in the history of the Nobel Prizes. So for the introduction of the insulin, they got the Nobel Prize. And then you have the A chain and the B chain. A chain with 21 amino acids, B chain with the 30 amino acids. Again, they got the Nobel Prize. And then in the B chain at the 28 and 29, you have the proline and the lysine. And then just dispersing that, you have the analog insulin, that is the glargine or the Lispro. So for that, they got the Nobel Prize. So the DNA of your insulin molecule, they got the Nobel Prize. So far, the 7 Nobel Prizes were given to the insulin molecule and insulin protein. So that is the most important thing to be known to all of you. So don't underestimate the value of the insulin in the management of the diabetes. So be familiar to know everything about the insulin. So please use insulin provided if the patient requires it. Don't postpone when they need it. For example, a uncontrolled diabetic foot ulcers. Okay, maggots are there. The patient is in septicemia. So don't try to give lot of the OHS. Just stop OHA and go on to start insulin therapy. Suppose the patient is in the GDM. Okay, so the blood sugars are not under control. So don't be happy with only metformin alone. So please just start insulin therapy. The patient is in the ICU with an acute myocardial infarction, even with the good control of the diabetes with OHS, but don't give the OHS in the ICUs. Always switch over to the insulin therapy. Again, pre-operative or intraoperative or post-operative, the subjecting for the major surgery. So again, stop all the OHS and take the advantages of the insulin. So you should know all the indications of the insulin in the diabetic life, and wherever there is an indication, please use insulin to avoid the complications of the surgery or any other thing or any admissions, and then you can improve the quality of the life of this population. See, the insulin comes to the India. Immediately in the same year, 2023, Indian physicians were using insulin for their patients. Is Dr. J.P. Bose, diabetologist from Kolkata, was one of the first to use the insulin in India and record his experience in the great detail. See some of the Bose patients before and after the insulin initiation. This is the first fellow, the girl. Here happily record the RIPS numbers also. What about the second picture? A little bit chubby. Okay, the same boy here, before the insulin and after the insulin. So this is the development of the insulin therapy. So earlier we have only the actrapids, and then we have the mixtards, then you have the long-acting insulin like the insulitards, then you have the rapid-acting analogs, and you have the basal analogs, and then you have the combination of these analogs, etc. So these are all the things. Non-insulin therapies. The first drug to be discovered for the diabetes is the insulin, way back in 1921. From 21 to say 50, no drug was there for the treatment of the diabetes, whether the type 1 diabetes or type 2 diabetes, you have only insulin. Only after 50 or 55, the metformin or sulfonylureas are entered into the market. So from the 55 till today, we have the lot of the OHS in our hand. So you have the sulfonylureas, you have the metformin, you have the thiazolidinediones like pioglitazone, you have alpha glucosidase inhibitors like voglibose, right now, earlier acarbose. Then you have the different gliptins, and also you have the SGLT2 inhibitors. So you have the hydroxychloroquine as an immunomodulator in some of the cases of the LADA. So these are the different drugs available right now in our hand. But for the first 30 to 40 years after the insulin, 21 up to 55, no drug was available except the insulin for all the people of the diabetes. So these are the different drugs. See the metformin, glibenclamide. So glibenclamide is the first, not the first sulfonylurea, earlier chlorpropamide. So that is very long-acting sulfonylurea causing more of the renal failure, etc. Then you have the glibenclamide, that is the dianyl, and later you have the glipizide, glyclazide, and glimepiride. So these four are the sulfonylureas available in our hand in our. So the metformin, earlier metformin is the penformin. So that was banned because of the more and more incidence of the metabolic acidosis and lactic acidosis. Now the metformin is entered into the market. Thiazolidinediones, you have the rosiglitazone and the pioglitazone. Rosiglitazone was banned because of the more and more cardiac effects. Now the pioglitazone we are using it. And alpha glucosidase inhibitors, we have the acarbose earlier, but acarbose is having more of the gastrointestinal side effects like nausea, vomiting, abdominal upset, belchings, diarrhea. So now we have the voglibose, 0.2 mg, 0.3 mg. GLP-1 receptor agonists, they are all the parental forms, liraglutide, dulaglutide, liraglutide, semaglutide, etc. Now the oral GLP-1 receptor agonist is available in the market, Ribelsus, that is the oral semaglutide. And then the DB4 inhibitors, you have the sitagliptin is the first gliptin entered into the market in 2016. After sitagliptin, you have the saxagliptin, veldagliptin, lenagliptin, teneligliptin, etc. And then the SGLT2 inhibitors 2013, that is the canagliflozin first, and then the empagliflozin, and now we are having the dapagliflozin. And the cana we are not using because of the peripheral vascular disease or the Foreigners gangrene or the gangrenous formations. Now we are using more of the DAPA and the empagliflozin. Now the dapagliflozin is almost a drug for the nephrologist and the cardiologist. Even we are having the non-diabetic period. Non-diabetics also, when they develop the heart failure, Now the dapagliflozin is one of the most important drugs to be prescribed in the heart failure, because in the heart failure you have the 4 pillars and one pillar is the SGLT2 inhibitors.